Good morning, and thank you for the opportunity to talk about our work here. I have to thank Io for a lot of his work on this project. Unfortunately, he wasn't able to be here today. No disclosures. Reducing length of stay is a national healthcare and local institutional priority. The goal for VQI centers for a prolonged length of stay over 2 days following elective EVARs is 12%. For the 2018 calendar year, our center was an outlier in the region for EVAR length of stay. 39% of our patients had a length of stay over 2 days. The objectives of phase 1 of the project were to 1, identify factors affecting length of stay after elective EVAR at our center, and 2, develop and implement an enhanced recovery protocol after elective EVAR. We conducted a retrospective review of data obtained from our local VQI module for EVAR procedures performed from 2013 to 2019. All elective EVARs were included. Excluded from the study were EVAR for symptomatic or ruptured aneurysms, all open AAA repairs, and all complex EVARs. A parallel multi-method approach combining qualitative and quantitative data was applied. We performed brief, semi-structured interviews with stakeholders, including surgeons, APPs, nursing managers, and service line administrators to identify areas for improvement in care until thematic saturation was achieved. The primary outcome was length of stay. Comparison groups were those with length of stay 1 to 2 days and length of stay over 2 days. Standard methods were used for a univariable comparison of peri-procedural factors, and a machine learning method was applied, including all available data to generate an adjusted multivariable predictive model. We included 216 elective EVAR procedures. The mean length of stay was 3.3 days, and after excluding outliers, mean length of stay was still 3.2 days. From stakeholder interviews, we identified the following modifiable variables that delayed early discharge: routine postoperative labs, routine postoperative PT evaluation, admission to the ICU, urinary retention, transportation home, and patient expectations. A univariable analysis of peri-procedural factors identified multiple factors as significantly different between the two groups. However, this was an unadjusted analysis. So we applied our machine learning model using Bayesian additive regression to create this multivariable analysis. So all preoperative and intraoperative characteristics included in the VQI were considered in the module. This tree summarizes the BART model predictors of length of stay over 2 days, and it allowed us to assess the importance of the variables studied. So the bubbles have the sample size and the mean probability of each group. Green indicates a lower probability of length of stay over 2 days, and red indicates a higher probability of length of stay over 2 days. So from this model, variables considered to be important included the access technique, anemia, renal function, beta blockers, insurance type, and functional status. The C statistic for this ROC was calculated at 89% to assess the predictive performance. This is consistent with a very good predictive model. Influenced by the BART model, we encouraged pre-procedure PT at the discretion of the surgeon, correction of preoperative anemia with medications over blood products, an ongoing emphasis on percutaneous access rather than open surgical femoral access. We also discontinued routine postoperative labs without clinical justification and discontinued routine postoperative physical therapy without clinical concern on post-op day 1. Excuse me. Lessons learned from the stakeholder interviews drove direct admission to the inpatient ward, bypassing the ICU. We encouraged the use of IV sedation and local anesthesia and protocolized management to mitigate urinary retention in the perioperative period. Furthermore, surgeons established realistic patient expectations for discharge on post-op day 1, and patients are instructed during pre-procedure education to arrange for a ride home on post-op day 1. This one-page enhanced recovery document was developed and circulated among surgeons, inpatient and outpatient APPs, nursing managers, and was provided to patients during their pre-procedure education. So implementation of this began at the end of August 2019, and the protocol in its current form was implemented in March 2020. The second phase of this initiative was to assess the degree of compliance with the enhanced recovery protocol, assess the pre- and post-implementation length of stay, and assess the individual components of the enhanced recovery protocol on length of stay. In phase 2, we reviewed elective EVARs performed at our center between July 2020 and June 2021. In total, 37 procedures pre and 37 post-enhanced recovery implementation were reviewed. There was no difference in demographics and preoperative risk factors besides a higher percentage of patients with heart failure pre-implementation. So first, compliance with all of the individual factors was assessed. Post-implementation, all patients had preoperative tamsulosin and had arranged a ride home. 29% had preoperative anemia, but none of them were corrected prior to surgery, and 1 patient had routine PT prior to surgery. 3 patients had PT after surgery. There were no significant differences in anesthesia and access techniques pre and post-implementation. Post-implementation, there were significantly fewer patients transferred to the ICU for recovery, and fewer patients had post-operative lab investigation. Next, length of stay was assessed. Post-implementation, the mean length of stay was 1.3 days. 1 patient had a length of stay of 9 days, and the proportion of patients with a length of stay over 2 days was decreased to 2.7% from 40.5%. A univariable analysis of the individual enhanced recovery protocol components on length of stay revealed fewer patients receiving preoperative tamsulosin and more patients having postoperative physical therapy associated with a prolonged length of stay. Other factors associated with the length of stay over 2 days were open surgical access, postoperative ICU transfer, and postoperative lab evaluation. On multivariable analysis, controlling for all factors included in the enhanced recovery protocol, postoperative physical therapy was the only factor associated or independently associated with a length of stay over 2 days. Finally, post-implementation, there were no significant changes in readmission, postoperative complications, ED visits, or 90-day mortality. So in summary, we utilized a multidisciplinary mixed method approach to inform an enhanced recovery protocol after elective EVAR. Post-implementation, elective EVAR with length of stay over 2 days was reduced from 40.5% to 2.7%, and there were no changes in readmission, ED visits, adverse events, or mortality. So thanks again to the program committee for the opportunity to discuss our work, to the VQI for a valuable data resource, and to all of my partners and collaborators at MCW and Froedtert Health. Thanks again.
We have a short 3 minutes for questions. Reminder, if you come to the mic, please identify yourself and your center of institution. Dr. Mansukhani, was a great analysis, and congratulate you on some of your findings for review. 2 questions I have for this you can answer briefly was, part of your analysis was on the evaluation of ERAS in terms of how it changed before you implemented this. My question to you is, I didn't see anything about the conversation or the expectation of the patient pre-op in terms of they're expecting to go home rather than that may take a while from that. Can you comment on that in terms of, do you change the messaging for the patient prior to having the procedure? The second comment was that it seemed that the use of physical therapy predicted the increased length of stay. Was that just because you didn't have the access to the physical therapist, and that was the actual delay that they could not just get to the patient in time?
Thank you. Those are 2 good questions. For setting patient expectations, that was one big thing. At our center, we have patients come from a fair distance, so setting the expectation that they will leave on post-op day 1 was a part of the enhanced recovery protocol. That seemed to make a big difference. And 2, access to the physical therapist wasn't necessarily the issue. It was more appropriateness of utilizing physical therapy. I think the routine physical therapy was a relic from when most of these procedures were done with open surgical access or from open aneurysm surgery. Now, the majority of these procedures are done with percutaneous access, so it's not even necessary. Once they're seen on morning rounds, if they're able to get up and walk around, then we don't even have the physical therapist see them anymore.
Louis Cabani from Detroit, Michigan. Very, very nice. And you identify a lot of factors that play a role in increasing length of stay. I'm going to go back and comment on your last thing. Is, do you think the change from open to endo really changed the length of stay? Because that's what we found when we started doing endo. We sent our patients home the next day or even the same day. So what was the main factor that you think changed the length of stay? If you had to pinpoint one factor, you think everything played a role?
Yeah, the reason we did that retrospective review in the second phase of this project is to see if there were any individual factors that directly influenced the length of stay. And I think if we would have done that initially and only changing physical therapy, that I don't think would actually make a difference in the length of stay. I think it was the bundled nature of this implementation and going through the whole process with multiple stakeholders and the whole system that got everyone to buy into it and coordinate and make this change together.
Thank you. In the interest of time, we'll go on, proceed with the next topic. Thank you.